Good evening, everyone, and welcome. I would like to welcome our guest speaker, Bianca Myers, to our class session, but the title of the presentation is Beyond the Social Determinants of Health, a Realistic Approach to Public Health Outcomes. So before we start, if you can just go around and introduce yourselves to our guest speaker, and then we can proceed.
I guess I'll start.
Yes.
I am Virginia Nemo. I'm a faculty at FDU. I'm a nurse practitioner, but I'm really interested in public health, especially health disparities, social determinants of health. And hopefully I will be able to do something with public policy.
Thank you. Ulrike?
Yeah. Hello, everyone. My name is Ulrike Pdsa. I teach public health policy, global health, comparative health classes here at FDU. And each class has always a big section about the social determinants of health. And my background is physical therapy. I used to lead rehab hospitals. Great to be here.
Thank you. Jennifer?
Good evening. My name is Jennifer, and this is my first semester here at FDU, and I would like to focus on health disparities within the minority community. Good evening, everyone.
Good evening. Magdalena?
Hi, I'm Magda. I am a FDU 3+4 and pharmacy MPH student, and I'm interested in public health to see what we as pharmacists can do to raise awareness in the community.
Mm-hmm. Thank you. Chooks?
Hi, my name is Chooks. I'm a pharmacy student, dual degree with MPH. I'm interested in MPH because I want to see if I can effect change in the inequalities and the quality of health out there in the communities.
Thank you. Margaret?
Good evening, everyone. My name is Margaret Hoover. I'm new to the MPH program at FDU, and I'm interested in healthcare law and policy.
Thank you. Claudel?
Hello, everyone. My name is Claudel Fontes, and I am a student at the pharmacy school, dual degree pharmacy student in MPH. I'm interested in MPH and able to work in programs that can help underserved communities.
Mm-hmm. Thank you. Christiana?
Hi, guys. My name is Christiana. I'm also in the MPH PharmD dual degree program. It's good to be here.
Mm-hmm. Thank you. And Gabriela is, she wrote, "Hi, I'm Gabriela. This is my first semester in the program. I'm interested in focusing on minority groups, immigrants, and the homeless. Nice to meet you all." Thank you, Gabriela. So I would like to introduce our guest speaker, Bianca Myers. I'm sorry. She is the Associate Director of Health Equity at Planned Parenthood Federation of America. Her expert knowledge and advocacy skills make her a dynamic facilitator of LGBTQ+, race and gender equity, and health disparities through an intersectoral lens. She is an adjunct professor at Monmouth University and currently co-chairs the Issues Committee of New Jersey HIV/AIDS Planning Group, initiative formed by the New Jersey Department of Health and Senior Services Division for HIV, STDs, and tuberculosis services. Bianca holds a Bachelor of Science in Applied Health and a minor in Women and Gender Studies from William Patterson University, and a Master of Public Health from Montclair State University, and is a certified health education specialist. Bianca, the podium is yours.
Thank you so much.
Thank you for being here.
Of course, I'm happy to be here. So I'm going to go ahead and get started just so we can make sure that we cover a lot, because I know we're going to be talking about quite a bit today. So just to give you all a little bit more background about today's conversation, we're going to be talking about a lot. I feel that when it comes to healthcare disparities and social determinants of health, that it needs to be approached the correct way and seen as an individual, communal, and systemic issue, because it is, and that we all play a huge role in how we show up for our patients and basically how we show up in our work environment. So you already introduced yourself to me, and that's great. If you want, you can put in the comment section what you bring to this space today and or what you hope to leave this space with. And we might get into this towards the end when we talk about, when we have an open discussion, I should say, around social determinants of health and health equity. So I do want to start with health equity first, and then I'll be moving on from there, but I'll do it overall. So health equity is really a high level of health for all people, focusing on how we can improve our societal efforts and how we can address inequities for all groups of people, but specifically speaking, those who have been marginalized or disadvantaged or left vulnerable. And these vulnerabilities or disadvantages are more historical, and I'll go into that in a little bit. When we're thinking about what actually determines our health, if you see here that majority of our health is determined not by our actual individual behaviors, not really by our physical environments, but more often so our socioeconomic factors. So how safe are you in your community? What kind of education do you or do you not receive? Do you have any kind of social or family support? And when we're looking at health disparities overall, and this is the updated one, because before, I'm not sure if you're familiar with this image, but before in the past, usually, I want to say usually this piece right here about racism and discrimination traditionally isn't in there. And I think that that's a vital piece of understanding social inequities, understanding determinants of health. It's racism embedded throughout economic stability or food or a healthcare system, which contributes to people not having the best language skills or reading or writing, which contributes to people having high morbidity or mortality, lower life expectancy, etc. This is the reason why our country is the way it is right now. And there's basically some key terms that are going to shift as I move forward. So it's important to know that the difference between a health disparity and an inequity is that disparity looks at a population health. It's more of an outcome that you're looking at versus inequities where you're looking at population health in ways that it's systemic or it's unjust. And we're going to be talking a little bit about both, but really the disparity doesn't address the chain of events that actually produce said inequity. And so when I'm working in a healthcare system, before I joined Planned Parenthood, I actually worked for Atlantic Health System for about 7 years. When I was working there, a lot of healthcare systems were first beginning with equality, right? When I would do trainings with providers, a lot of them would say like, oh, this is great, Bianca, but I treat all my patients equally. And I would always push back and say, you know what, you cannot treat people equally. When people come to the emergency department, when people come to patient access or scheduled surgeries, not every patient is going to be treated the same, and that's okay, right? We need to be focusing more on health equity instead. So really looking at the unique reasons why patients land in our emergency rooms or why patients come up to our healthcare centers. We can't have a blanket approach to everyone because traditionally we've always done that, and see how we have gaps in the healthcare system now because we tried to give everyone the blanket approach to healthcare equality. And so we have to think about, how do we make this fair? How do we make this just? How do we talk about obstacles that are larger and impact a lot of people? So I noticed housing or homelessness was a topic of interest. How do we address that? We have to go bigger here. We have to think about, why are people homeless? We have to think about, why are people living in poor neighborhoods, et cetera. And all of this is pretty much rooted in structural inequities, right? So these structural pieces produce systemic disadvantages. They produce inequitable experiences for social determinants of health. And that's what shapes your healthcare outcomes. So when you're thinking about all these big pieces of where you live, how it could contribute to your transportation options or your air quality, thinking about the people in your area. Is it safe from crime? Is there any segregation in your area? And we have to think, how do we actually apply a health equity lens to this, right? Because I would say with the pandemic, there's a lot more talk around equity and what that actually means. It's not always been this intentional before in the public health field. I remember when I was in school and I told people, oh, I'm in school for public health. At the time, no one knew what that meant. They didn't know what health equity was. And even still, I think people use health equity pretty loosely, but I want us to get a little bit more specific here. So we have to think about the lens even more and ask ourselves and our system some harder questions. So who is impacted by the systems that we have in place? Who are we intentionally or unintentionally leaving out? What assumptions do we bring to this work? Who makes the decisions at the table? And very often it's not the community that we're trying to serve. They are people outside of the community or people that are put in place to make the decisions. Even the data that we collect, when we're looking at research and we're saying, hey, 90% of the survey participants are middle class. Guess what? That means that you left out other people of different socioeconomic status. And that means that we need to do a better job of surveying, collecting data from our patients and not just taking one survey and applying it onto a mass population, because we know that that doesn't work anymore. We have to widen it. How do we promote healthy behavior? That's a conventional question, right? We are always asking ourselves, how can we do that? The question we should be asking instead is, how can we target conditions that exist and reorganize things, policies, and land to ensure that people have healthy places or spaces? Move away from questions that are convenient or conventional, like how do we replace disparities in the distribution of disease and illness, to thinking about how do we eliminate inequities in the distribution of resources and power that actually shape healthcare outcomes. And part of that is we have to do the work, right? There's a lot of individualness where we have to actively seek out knowledge. A lot of us, when we were in school, we were not taught adequately about inequities. We were not taught about systemic racism or white supremacy. We have to learn about these things ourselves in professional development or through other institutions. And also we have to think about how we show up in the work. What kind of bias do we bring to this work? And just, as I'm thinking about bias, we all have a bias, right? You have a bias as a provider, as a college student, as an American, and we bring all of these to the healthcare, whether we're being intentional or not. But we can find power in our knowledge. We can find power in our identities as we bring that there. And it's important that as we're trying to get towards health equity, that we are also creating programs that can help us get there. We need to measure things better, and we have to have stronger policies and build an infrastructure on how we do that. So how do we do that? How do we build a strong infrastructure? You have to have a social justice lens. You have to care about social justice. To be in the field of public health and not care about social justice is a hard road. This is a quote by Kimberly Crenshaw, who was very popular and well known for her intersectionality theory, in which the idea that we all have the same life is false. People's race and class and gender come in a way that can make things really different for you. Whether it's better or worse, that really depends on the factors and the environment that you're in. And so first, I want to think about, let's look at our identities that we bring to this field. Identities are something that everyone has. They can give you a lot of self-esteem or individuality, or make you feel like you're a sense of a community. And there are identities that are deemed positive, and there are identities that are seen sometimes negative or destructive. Again, looking at the construct of whatever societal expectations are on you. And then we have people that are, Then we have people that are marginalized, right? So these are people or groups of communities that are deemed unimportant or powerless within a society because of their position. And so in this picture here, I have people protesting, and there's different kinds of marginalization. It's not just for women, it's not just for climate change. When we look at our identities, right, we have to think about, how do people identify themselves? Usually people identify themselves within the big nine. So your class, your ethnicity, gender, race, or religion, but we know that there's other social categories as well too. So your learning style, what kind of academic or social achievement that you might have, any kind of political beliefs you bring to the table, or body image. There's also things like immigration status, right? Or your age or the stage of life that you're in. And when we're looking at all these identities, we have to be able to identify that there are some pieces of our identity that give us more power and privilege than others. And so I like to use the concentric circles activity, in which the outer ring of your identity that you choose is the identity that you think about the least. It's your power, it's your privilege. And as I told my students last night, some students say, like, I don't think I'm privileged. I don't really have an identity. You do, right? You're in this lecture. You go to a university. That is a huge privilege. There are people that will not make it to academia in any way, shape, or form. And so even being here in this lecture is something that gives a lot of power and privilege over other groups. Your middle identity is something that you would occasionally think about. So maybe this is based off of your lived experiences. And then the center identity is something that you would think about all the time that may or may not have experienced any kind of marginalization or any kind of oppression. And so I'll use myself as an example. So on the outer circle, I would put my sexual orientation. I identify myself as queer. To me, that's on the outer ring because I work at Planned Parenthood. We're very LGBTQ inclusive. If I bring my wife to be to a work event, no one is going to say, like, what is she doing here, or treat us any differently because of where we work. And that's not something I think about. On the middle part, I would put my class. I think about my class often enough, and based off of my lived experiences, I navigate the world through that. And then for me, my center identity would be my race. So I identify as Black or African American. And I think about being Black all the time because of the things going on in this country, because of the racial reckoning that happened last year, and because of the environment that I grew up in. Very often, sometimes I was the only person that looked like me in a room. And that made, when I was younger, that made me very self-conscious. So thinking about these identities and how they play a big part, we all have ways to identify ourselves. And I encourage you, when you have some time, think about how you identify within these concentric circles and how it shows up in your work, and you'd be surprised. It's really important that we're taking intersectionality into the work environment, because we know that we're all just not one identity, right? We are the summation of all of our multiple identities. And that's what makes us all very beautiful and unique and respected in our cultures. But we do know that there are groups that have been seen as more advantaged than other groups. And so as we are thinking about healthcare and health disparities, we need to think about people that are in the advantaged group and the disadvantaged group, people that are seen as marginalized or unprivileged, or they like to use the term minority groups. And we need to be able to think of patients like this, of our target populations, and be able to think about the biases and perceptions within the privileges that we hold. I'm gonna keep going. We live in a society that most of our laws, majority of our norms that are put in place by communities that have a lot of privilege and power. So if we're thinking about people that are able-bodied, or if we're thinking about people that are male, that are more likely to be heads of hospitals or CEOs at a healthcare system, right? We need to think about all these identities and how they show up, and how they show up in our patients. So there's a minority stress theory in which if you belong to any marginalized or minority deemed group, that you are more likely as an individual person to experience stress than someone that's not in that minority group. And the more minority identities that you have, the more likely you are going to experience stress. And that comes up and it shows up in the body. It shows up in people's coping skills and their mechanisms. It shows up when we're taking their vitals. And so we have to examine ourselves first to be able to make organizational change. We have to think about, what are we doing? Are we building up resiliency skills to really advocate for equitable work? How do we bring these best practices forward? How do we make sure that we're doing things that are actually convenient to the patient? I challenge people and systems to think about their mission statement. A lot of organizations have been around for a really long time and they don't update anything about their systems or their practices or values or mission to reflect 2021, and we need them to. We need organizations to think about their standard operating procedures or white supremacy culture. Ooh, I'm sorry. And we need them to think about how harms happen to Black, Indigenous, people of color. That's what BIPOC means. So anytime you're working with healthcare disparities, you need to be thinking about, how does this impact these communities? Are they being tokenized? Do they not see themselves reflected in the healthcare system? What kind of support do they need? And take a minute to see, is this familiar to you? Does it show up? Do we expect more from BIPOC people when we reach out to them, or are we blaming BIPOC patients for their healthcare disparities when they come in? We also need to be thinking about LGBTQ people as well. So it's race, it's LGBTQ status, etc. And thinking about, how do we elevate voices of people within our personal and our professional circles. So I'm gonna, just for time's sake, I'm gonna skip a little bit forward to the disparity part because I want to make sure I have enough time for that. So improving healthcare outcomes. It's a big picture to be able to say, oh, we want to decrease the amount of STIs at Planned Parenthood or any healthcare institution. But how do you actually do that? You need a framework, you need a plan. And so this is an organization that has helped my institution, but also has this great resources online in which they have a framework of 5 drivers that will help healthcare systems be able to address all the multiple determinants of health and health equity. And so first, you have to be able to make health equity a strategic priority. You must have leadership commitment. You need to have sustainable funding for this, right? Any kind of institutional change, you're gonna need big picture items. You need to develop an infrastructure to support this work. You know, very often people think that you can hire one public health official and they'll be able to get the job done for an entire healthcare system or industry. And that's just not true. You need a team, you need people in different positions to be able to make that work. To address the multiple determinants of health, you need to be able to change the entire system. So that means promoting healthy behavior, changing up a physical environment of the healthcare system so that it's more patient-friendly, thinking about socioeconomic status. So how are we bringing in patients with different insurances or no insurance? And how are we switching up the healthcare services that we give them? And that might mean asking hard questions around like, hey, should we be offering these kinds of services because we know people in this area need it? And how do we do that? Also thinking about institutional racism within an organization. We need to make sure that we have better health insurance plans and that we're reducing bias in organizational structures or policies. And you need to make sure to work with the community, because I've seen time and time again, healthcare systems think that they can solve the issue without bringing the community in, without bringing in those community partners, that those nonprofits that are in the general area, or even the county public health department. You need as many allies as you can get to really address these determinants of health. And part of this is, I'm going to go through the drivers a little bit more. Part of this is, for health equity strategy, you need to be able to address your own institution's context of inequity. If you don't, your patients, your target audience, and even your stakeholders are going to hold you to it. You need to make sure that you have appropriate resources, budget goals, and departments to be able to work towards a strategic plan, and the commitment of your leadership to be able to make this happen. And this has been shown to work when you have staff that care and able to recognize their own bias, when you have resources or improve your health literacy or language services, when you build up teams, not only with public health officials, but also clinicians as well, right? Because we know that with health equity is a plan, but quality improvement is how you get to the plan. And you need both to be able to make that happen, especially on the clinician side. And you need to be able to develop programs that specifically meet your patient population. For the infrastructure, you have to look at where are the gaps in equity and track that over time. You want to make sure that the whatever platform you're using, you're able to disaggregate data, and you're able to clarify for your team who's working on what and have a dedicated space. Building the capacity within your own team to be able to do this. Thinking about determinants of health, you'd be surprised, there are lots of data systems that exist, and you can't tailor efforts to be able to really highlight which population needs which intervention. So finding a system, finding a protocol that works for your healthcare system is so important. Looking at ACEs, adverse childhood experiences, when clients show up, or using trauma-informed care is super important here. You have to look for ways to apply interventions that target multiple determinants of health, not just one intervention. And sometimes you need to challenge your healthcare system to come up with an intervention that's not convenient to the healthcare system. Sometimes we have to take a step back and say, hey, what's convenient to our patients? So I'll give you an example. At Planned Parenthood, it's convenient to have evening hours for our patients. So what do? You start offering evening hours. Not that it's not convenient for the staff, because you can always try and hire some nighttime help, but think about ways that you can bring in patients and make it easier for them to be able to get a visit at a doctor's office, or easier to navigate a healthcare system, because a lot of patients come in and they're overwhelmed and they're afraid and they don't know what to do. And that's where we need to meet them where we are, or meet them where they are, excuse me. When it comes to the institutionalized racism, we have to normalize conversations talking about race and systems of oppression. We just do. There's no way to dance around it. There's no way to beat around the bush. We have to do that. And we have to make sure that we are hiring more people of color, that we're hiring more women in spaces, that we're bringing in people and holding them. We're having strong retention for them as well. And that healthcare systems are also talking about racial equity. And in terms of partnering with our, yes, evening hours, Gabriela, is perfect. I hope eventually we'll all have more evening hours, thinking about people that work and can't take off. It's a privilege to be able to take off of work to go to the doctor's office. And when you're in the working environment, they only give you a certain amount of days to take off, and you have to balance that with vacation and other familial obligations that you may or may not have. So yeah, we have to get innovative in terms of what we're offering people. And when we partner with community organizations, it's really important that we share power with them. It's very important that we are not having a transactional relationship with our community partners. We want them to feel equally heard and validated when we work with them. So for us, it could be working with patient panels or affinity boards. It could be working with small nonprofits. We really want to make sure that they also are showing up for us the same way that we're showing up for them. And so thinking about multiple determinants of health even more, we're thinking about the overall picture of things. Pardon me. Try not to. I will give you all access to this presentation. I don't want to play the video for connectivity issues. I just said I'm not playing it. There we go. So I'll give you all access to this presentation so that you can, go through the videos on your own. They're very informative, and I suggest you do that. But I want to spend more time talking about the overall picture of what needs to be done. So looking at these behaviors and stuff. this is the video, the one video that I want to play because I think that it's extremely helpful. So this is the science of improvement. So thinking about, okay, now that we know what to do and we know to do the internal work, how do we move this forward? When you are trying to address multiple determinants of health, you need to think about how do you get everyone else on board? What kind of buy-in do I need from other departments, from other teams, from patients, et cetera? And that's where the science of improvement comes in.
So why does everybody need to understand the basics of improvement? Well, essentially, we don't really know the answers to our biggest complex quality and safety issues today. And we need to really make sure that we involve everybody in helping us discover solutions to these problems. So everybody needs in their day-to-day practice a way to solve challenges and fix things without needing to ask permission. And the tools of improvement give you a way to do that.
Seeing things through an improvement lens can help you to, instead of continuing to do those workarounds and create additional steps and additional waste, really think about how can I do this differently? What ideas can I try today to make this better for my own work?
Improvement is a skill. It needs practice and refinement over time. It's all the softer stuff around improvement. So how do you influence and engage people? How do you really do this work in practice in the midst of a really busy environment where you're functioning on a day-to-day or minute-to-minute basis, and yet thinking about how do you improve things for tomorrow? That's a skill, and that needs lots and lots of practice to hone and refine.
We're all experts in a certain content area. You might be a nurse or a doctor or a data technician, whatever it is, you have that content knowledge expertise. I think for everyone, it's important to know a little bit of the science of improvement and incorporating that into your daily work, because it can show up in the ways that you look at your data, the way that you think about data, the way that you see the process from a different perspective, like appreciating the system you're working in and thinking about how patients are moving through that system or whoever the customers are. We can bring that into our daily work and thinking about our own workflows and policies and patient engagement on a different level by having that desire to learn and improve in our everyday.
Oh, oops, sorry about that. All right. Brief technological issue. Perfect. Okay. All right. And then as we're thinking about improvement science, there's also an aspect to think about called the Pdsa. So that is the plan, do, study, and act cycle. You may or may not be familiar with it. I'm a big fan of it. It's really important that when we do this, we're thinking about multiple plans and multiple forms of action. It's not enough to only make one plan of action, like, oh, we're going to increase our patients. No, there has to be other aspects of it too. So first, using the health equity framework, and then with each driver, you can make a plan. So you can make a plan to make sure health equity a strategic priority. You can make a plan to partner with community. And basically you need to think about what's feasible for you and what is the end result. And also making sure that you are keeping your community involved as well. So you're thinking to yourself, what are you trying to accomplish? How do we know that there's actually going to be improvement here? And what changes can we actually do? And most of the time, I want to say that it's not just a one cycle plan. From working in the health equity space and looking at social determinants of health, I can assure you that you'll be constantly going around and around in these circles trying to figure out, like, what is the best way? How do we change the plan? How do we do a better job at the test? Or how do we analyze the data in a more efficient way? Thinking about the policies of organizations, super important to think about who benefits if we don't change the policy, or thinking about specifically the physical environments of communal partners it's time to start getting uncomfortable in healthcare. I mean, I'm just going to call it what it is. So I like this picture at the bottom. It shows Mount Sinai Health System walking in a pride parade, right? That's meeting a community system that has been marginalized from the healthcare industry for a long time, exactly where they are. It's okay to find those non-traditional ways of reaching out to the community. So lessons learned. I think very often in the public health space that when we create initiatives, we only talk about when we succeed. We don't talk about the failures or the missteps that we've taken along the way. But I think that we should. I mean, we could show people that we are vulnerable and that we are accountable. We can prevent other systems or healthcare agencies from making similar mistakes. We can contribute to the massive field of healthcare and public health. And we can provide building blocks for other areas of improvement to be revisited. You know, I think we can learn off of each other when we are able to post and talk about our missteps in the field. And I also think that we are, as healthcare professionals, going to fail at some point. That is a part of the game. And that if we do fail, we need to fail forward. So maybe you had an initiative that was supposed to, I don't know, increase COVID vaccinations and you weren't successful the first time. Okay, so you write your lesson down, you share your lesson out as to how you weren't successful, and then you try again. And hopefully in you being able to share your lessons learned, you might be contacted by another agency that says, hey, I saw that you all tried this method. Have you tried this instead? Exactly. We're all human, trying to do our best. And I think that we need to apply the human approach to public health and to these initiatives after thinking about applying the health equity work and the framework as well. So I want to leave some time for Q&A. And I'm going to bring down my screen so you're not going to be staring at this.
Thank you, Bianca. This was really very interesting and enlightening. I think that we also reviewed quite a few determinants of health and social determinants of health. And so I think it's important. I'd like to invite everyone to share comments, questions, and to begin the discussion.
I can start with something that was really super well presented. Thank you so much. And I'm glad you brought up the disparities and inequities. I know it's used so much interchangeable, and I finally got a clear definition. Thank you for that. And I also, you know, your visual, I've seen that visual before, the equality and equity, I've seen that before, but that is such a good reminder, because we don't think about that. And then some others, I took notes as well, I'm looking down. The structural inequities, they were very helpful, that part. And Kimberly's quote, you know, there was, and then you could, your circles, your
concentric,
concentric, I couldn't, I couldn't read my own handwriting. The circles, and I was thinking, I always identify myself as German, and it's like, still after I came to the US in 91, so why is that so important to me? It's kind of stuck in my inner circle, which is very interesting. And then the middle one is the healthcare. Always healthcare is, that's my industry, but it's interesting. So.
Mm-hmm.
Yeah, I often find that when people do the circles too, that sometimes it's hard to narrow down which parts of you go into which pieces. And I always encourage people, you know, like these circles can change at any time, depending on your environment, you know. So like at some time, my middle circle is academia because I'm always in it. But it can change. And I encourage you all to you know, practice doing that with your loved ones, you'll even see like how people identify which identity really centers them versus the other ones that they don't really think about.
Yeah.
You could almost do also values in an inner, middle, and outer, you know, not just who you are, but what are your values. And so that would be very cool for relationships. Thank you.
Mhm. Any other thoughts, Raymond? We had a very good and fruitful discussion a couple of weeks ago, and we started talking in both classes actually, and we started talking about those issues that all of us have, and very often, you know, talking about these concentric circles, very often we do identify ourselves with the issues that really are at the core of our interest, even professional interest. So, you know, this professional personal really crosses. And I agree, it depends on the context where we are. We probably focus or put that middle, the center one ahead of others, and that's important.
Absolutely. I encourage people, bring those identities to work. Don't leave them at home, because when you're in a room creating a strategic plan, or you're creating project development, you could be bringing those identities of people that are like you to the room where they never would have been in before. Thinking about when I was in grad school and we wanted to go into Paterson, New Jersey, which majority of people that are in Paterson, New Jersey are Hispanic. And we wanted to make sure that we were bringing in cultural aspects and not taking the, you know, scrubbing clean, like, oh, we're going to teach you how to eat healthy, but like not exclude any of your culture's food in the plan for you to eat healthy. And how if we were also giving people handouts, and we wanted to make sure that, hey, these handouts need to be in Spanish, because realistically, Spanish is the language of Paterson. We can't just, as public health officials, just go in and say, we're going to lower people's glucose by giving them English-speaking, English language only pamphlets that only have food groups that, or food items that people don't know or people don't identify. And we even went into bodegas. We went into bodegas and we were talking to the shopkeep and handing out stuff for them as well, working with Goya to make sure that we had brand names that people in the community recognize as part of their community, as part of their healthy eating behaviors. That's how you get to a community. You can't just take that approach specifically, because the same way that I went to Paterson and did that, I can't do that with Newark, or I can't do that with Camden, or Summit, New Jersey, or Morristown. You have to get specific with whatever group that you're working with. It's the only way, right, Gabriella? It's the only way to get the trust and understanding, because at the end of the day, sometimes people look at you as an outsider, even when you're trying to keep that population in mind. Mm-hmm. So there's a lot of trust building that needs to happen for sure.
Mm-hmm. Yeah.
And I see a comment here about, yes, focusing on inclusion instead of diversity. Yeah, I think it's, you know, diversity is important, but, you know, I usually, sometimes when I get asked to speak, very often people are like, oh, you know, we want to be able to hear your voice, Bianca, because, you know, you have so much diversity in your identities. And sometimes I pause and tell people, you know, like when I speak, I can only give you my background, and like my background and my experience does not represent this entire communal group. That you have to go out and think and talk to other people of color, or other women, or other people that identify within the LGBT spectrum, because they're all going to think very differently than me. And that's why I like what you said about diversity is okay, but inclusion is better, because now you're bringing different kinds of people to the table.
Mhm.
That's what's important.
Mhm.
Yeah. And especially what do we have in common, instead of, oh, you know, you're this origin or this and this industry. No, what do we have in common, and what's our common goal and focus?
Absolutely. When I was in grad school, I had the experience of having classmates come from different countries, and we would have open discussions as a class. And I remember this one question. I had a classmate ask us, why is it that America seems to not being able to come together because of the differences? And I told them my honest opinion. I said, we are one of the few countries that has the most diverse people. So whenever you try to get the most diverse people together to go in one direction, it's hard. Like, look at other countries. Most people might look like you. Most people speak the same language as you. Most people worship the same God or have the same religion as you, right? America is unique sometimes because we have all these different kinds of people, and that makes us, you know, special as a country sometimes, but it also creates a lot of major challenges, because now you have all these different mindsets coming to the table in terms of trying to reach out to people and making sure that everyone is heard. So it's definitely a challenge, but I think that it's a good challenge that we have so much diversity here. But we have to work almost twice as hard to make sure that we're as inclusive as some of the other countries, because we have so many categories in which we need to be more inclusive of. So certainly some work to do on our end, but you know, this is the way it is. But I'm encouraged. We were talking before you students joined, we were talking about how younger generations are more aware of global issues and how they bring that into the field. And I think that's a wonderful thing. I hope that we're able to elect, you know, leaders and support and get support from leaders within our companies as well as politically that are thinking about the larger, harder, more nuanced conversations, because it's time. It's time we have those conversations because it's impacting people's health. And we want to make sure that we increase our life expectancy here, that we're having, you know, healthier behaviors here. That's also vital in this life.
Yep.
Yes, someone? I thought someone wanted to say something. I agree with everything that everyone said, and thank you for this comment. I was really glad to hear. Very often in research, we say we should publish everything that we, you know, whatever the study was about, even if we do not confirm our hypotheses, we should report on that. And that's the point of building knowledge and, you know, communicating within the scientific community about our successes and I wouldn't say failures, you know, just maybe finding out something or lessons learned, finding out something that we did not expect. Those missteps that you mentioned and errors, really in the public health practice, those should be emphasized, you know, not in the sense to demean or to disqualify someone, but really to learn from those, what it is that we are doing not the right way, that's not bringing success, you know, and learning from those. I think it's really very important, and focusing on those might help us overcome some issues, and then again, it could bring us together, different teams, different groups, different ethnic, religious, and however you want to see, different communities might come together and solve the issue if the lessons learned are shared with everyone and we know more. And there is no point in making the same mistake over and over in different contexts and settings, right? It's much better to actually learn from those. So I thought it was really a great point. I think it's
Just looking at research studies, my favorite section of reading a study is actually the limitations. That's actually my favorite part,
Yes.
because I'm thinking like, oh, you know, look at all these limits. Time to think about the next time. That's my favorite part to write and my favorite part to read, because every study should have limitations.
Yes.
Every study has shortcomings. You know, you have all these plans about how you're going to recruit people, or you know, you think your methodology is correct, and sometimes it just isn't. And that's
right. But it's true. Someone has a comment in the chat. Yeah, Jennifer is saying absolutely, that's such a powerful statement. Bring your identity to work and be the change. I think it's in reference to something that we discussed before. And Gabriella is stepping stones to our goals. That's true. To achieving the goals.
Absolutely. And don't be afraid to stop, like to pause, I should say, your goals too. You know, very often we're about to launch something and a community member like reaches out and says like, hey, you all missed the mark, and we have to take a pause, go back to the planning part, and then take into consideration the feedback that we got, and then plan for the future. So don't feel bad to pause the work that you're doing sometimes. I think that there's very often a sense of urgency professionally, and that is a part of, you know, white supremacist themes of like always having to get things done regardless of timeline or regardless of etc. But you know, I think to do good work, it needs to be very intentional. It's better to be intentional about your work and to take your time than to rush and do something and cause communal harm in which you break the trust of the patients that you're trying to reach, especially people in communities that belong to marginalized or underserved communities. They're the ones that definitely deserve more intentionality from our end as professionals when we interact with them.
So very true, yes. And those are the communities that really need the most, they are most vulnerable, but they also need the most attention and time. And you're right, very often we hurry to do something. There are always deadlines. There is, especially in academia, we need to submit our dossiers. You know, something is pressing, and something is, and then really when you stop and think, is it really? Is that really the point? Or if we are doing research in the community, that's why I really like a community-based participatory research, where you begin from the beginning of any research, you involve community members. So you actually build a study, or you build a project, something together with community members, and then it takes its own pace. Just like when we discuss, when we have class discussions, and if we are doing really inquiry into a topic, it takes time, and very often we do not cover the whole, you know, whatever the lesson plan is about. But if we really addressed and attended to something that is really very important to everyone who is included, that's the most important thing. That brings the most valuable outcomes, and that changes the outcomes, even health outcomes, and that changes a lot in people's lives.
Absolutely. And we have to remember as professionals that just because we're on a schedule does not mean the community's on the schedule.
And that's true.
You know, and it's so important to get the community involved in the beginning, because the worst thing you can do is put together a plan and then propose it to the community and it doesn't resonate with them at all. And then you have to go back to the planning board and say, okay, well, that was not what we needed. We should have incorporated the community in this work first, even if we had a draft plan. I'm also a big fan of sharing draft plans as well. You don't have to have it all figured out when you show it to people. In fact, I encourage it. People, like, even if you have it like 75% done, show someone. Don't wait until it's absolutely finished, because you might end up having to adjust it anyway.
Right, right. And you have outcomes that are not realistic. And this is why I think we have these outcomes that are not really comparable to other countries. Just to go, just to look at the health outcomes and health status in comparison with other countries that might have a little better organized systems of health. Any other thoughts? Yes, community members should be part of in every step of that. That's true.
I have one more last thought, and it's around data equity, because I know that that's also a part of addressing determinants of health. And I think that each system needs to do a significantly better job at collecting data, especially around race and ethnicity. I mean, there are categories for race and ethnicity that have existed since the 1950s. And as this country is becoming increasingly more people of color centric in terms of, population, if you're looking at population trends, there's going to actually be more people of color within the next 20 years in this country, or people from different countries and different backgrounds and ethnicities. It's definitely time that we step up and how we ask people how they identify themselves. It's not enough to just have white, black, and other. It's not enough to have white, black, and Hispanic other, or just a category of Asian, because, Asian could be Polynesian, Pacific Islander, it could be, someone from India. Like, it's just, we need to do a significantly better job of that. And we need to make sure that it's a lot more nuanced, honestly, because unfortunately the data determines resources and how things get allocated. So if you're not asking the right questions, you will never get the right information. You will never understand the right target groups or how many people utilize a service if we keep asking race and ethnicity questions the same way.
That's true. That's true. Thank you very much. Thank you, Bianca, really very much for this enlightening presentation and discussion, and so many good points and lessons we learned tonight.
All right. Thanks, everyone. I hope you all have a good night.
Thank you.
Thank you.
That was great. Thank you so much.
Bye.
Bye-bye.
Bye, Bianca.